Have you ever noticed how medicine grows louder as we grow older? The commercials become more urgent, the checklists longer, the promises brighter. Scan this, test that, don't miss a thing. And yet, after 16 years at the bedside, I have come to a quiet confession that may unsettle some of my colleagues. More testing does not always mean more life. Hi, I'm Dr. Melina, a physician and longevity researcher, and what I'm about to share is not rebellion, but responsibility. There is a dilemma that lives inside modern medicine. On one hand, we fear missing something. On the other, we rarely speak about what happens after we find something that was never going to matter. A shadow, a cyst, a nodule, a word like abnormal printed in bold ink. What if the real risk is not the disease we're searching for, but the chain reaction we trigger once we start looking? I've watched vibrant men and women in their 70s walk into a clinic feeling well, only to leave months later exhausted by appointments, frightened by terminology, and recovering from procedures they never truly needed. Studies on overdiagnosis and incidental findings suggest this phenomenon is not rare in older adults. Imaging technology is so sensitive that it almost guarantees discovery of harmless age-related changes. So let me ask you something gently but honestly. When we search for everything, do we always find health, or do we sometimes manufacture illness? That uneasy feeling you may sense is the beginning of what I call the Cascade Effect. It rarely starts with illness. It begins with reassurance, a precautionary scan, a routine check before a minor procedure, a family member saying, "Let's just make sure." And then, almost inevitably, something appears: a small shadow on a lung, a cyst on a kidney, a faint irregularity described in careful radiology language. Harmless most of the time, but impossible to ignore. Here is how the cascade unfolds. At 4, a healthy person agrees to a test for peace of mind. At 3, an incidentaloma is discovered, an incidental finding, common in aging bodies. At 2, referrals multiply, specialists, repeat imaging, consultations layered upon consultations. And at 1, the most dangerous step, an invasive biopsy, a catheterization, a surgery, all to investigate something that, in the majority of cases, would never have shortened a life. Research on overdiagnosis shows that increased screening often raises detection rates without reducing overall mortality, particularly in older populations. In other words, we find more abnormalities, but we do not necessarily save more lives. What we do increase consistently is anxiety, procedural risk, and exposure to harm. I once cared for a 72-year-old woman whose tiny spot led to 3 procedures and months of fear, only to confirm it was benign. She told me, "I felt sicker from the testing than from aging." So the question becomes unavoidable. When does vigilance quietly transform into vulnerability? To understand why this happens, we have to confront something uncomfortable. Aging bodies look imperfect on high-definition imaging, and imperfection in medicine is often mistaken for pathology. By the time we reach our 60s and 70s, cellular senescence has quietly accumulated, telomeres have shortened, and tissues have remodeled themselves in response to decades of living. None of this is failure. It is biology unfolding. On a scan, however, normal aging can appear dramatic. Small lung nodules, benign kidney cysts, mild spinal degeneration, white matter changes in the brain.
Radiologists even have a term for these surprises: incidentalomas, findings unrelated to symptoms and usually harmless. Large imaging reviews show that incidental findings are extraordinarily common in asymptomatic adults, increasing with age. O'Sullivan et al., 2018. In other words, if you look hard enough, you will almost certainly find something. But here is the deeper truth. Technology now sees more than our clinical wisdom can meaningfully interpret. The resolution of modern MRI and CT scans has advanced faster than our ability to distinguish which abnormalities matter. The result? We label age-related wrinkles on the inside as threats. Imagine zooming into your hands with a microscope powerful enough to reveal every scar, every sunspot, every collagen shift. Would you call that disease or simply evidence of time? If aging is written into our tissues at the cellular level, why are we so quick to call its signatures dangerous?
This is why the first checkup I approach with profound caution is the full-body scan, the promise that we can catch everything early. It sounds irresistible, especially after 60. One appointment, one machine, total clarity. But medicine does not work that way. At 4, the appeal, a whole-body MRI or CT scan that surveys every organ in exquisite detail. At 3, the discovery, tiny lung nodules, liver cysts, adrenal incidentalomas, most of which are statistically benign in older adults. At 2, the follow-up imaging, sometimes every 6 months, to watch something that was never causing harm. And at 1, the possibility of biopsy or surgery with risks of bleeding, infection, or procedural complications, all in pursuit of certainty. Studies examining whole-body screening in asymptomatic individuals show high rates of incidental findings without clear evidence of improved mortality outcomes. What does increase consistently is downstream testing and psychological distress. Anxiety becomes the silent side effect. I have seen patients who felt vibrant before a scan begin to describe themselves as a ticking time bomb afterward, even when nothing dangerous was ever found. And here is the paradox. The more detailed the image, the more likely it is to reveal normal aging masquerading as pathology. Mitochondria may slow, tissues may stiffen, but that does not mean disease is inevitable. So let me ask you gently, is peace of mind truly gained by seeing everything, or is it sometimes surrendered the moment we do? What I have learned, slowly and sometimes painfully, is that images can seduce us into mistaking visibility for wisdom. A scan shows structure. It does not show resilience. It cannot measure mitochondrial efficiency, insulin sensitivity, or the subtle choreography of balance and coordination that keeps you independent. It captures anatomy in a frozen frame, while health is motion. I think of a 68-year-old man who proudly told me he could carry groceries up 2 flights of stairs without stopping. His MRI report, however, listed degenerative discs, small vessel changes, and a benign cyst. On paper, he looked fragile. In life, he was powerful. Which version was true? Functional health often predicts outcomes more reliably than imaging in older adults. Walking speed, grip strength, balance, aerobic capacity, medication burden. Gait speed alone has been associated with survival in multiple cohort studies. That is not because walking is magical, it is because movement reflects integrated systems, cardiovascular efficiency, neuromuscular coordination, metabolic stability. A scan cannot see that orchestration. Medicine, over time, drifted toward screens. It became easier to trust pixels than patients' stories. But aging is not a radiological event. It is a physiological narrative unfolding through circadian biology, cellular repair, and adaptation. So I often ask my patients a different question. Can you rise from a chair without using your hands? Can you walk briskly and recover your breath? These are not glamorous metrics, but they are honest. If health is something you live rather than something you photograph, why are we so quick to outsource it to machines? The second checkup I approach with deep caution is the brain MRI ordered for minor memory lapses. Few fears are as powerful as Alzheimer's disease. A misplaced name, a forgotten appointment, and suddenly families whisper about degeneration. The reflex is immediate. Let's get a scan. At 4, the concern feels reasonable. At 3, the MRI report returns with phrases like mild cortical atrophy or white matter hyperintensities. At 2, those words are interpreted as impending decline. And at 1, anxiety settles in, sometimes more disabling than the memory issue itself. Here is what is rarely explained clearly. Structural brain changes are extraordinarily common with age. Studies show that mild atrophy and small vessel changes increase steadily after 60 and often correlate poorly with cognitive performance. I have met sharp, witty 78-year-olds whose MRIs looked alarming on paper, and confused individuals whose scans appeared relatively unremarkable. The image does not equal the identity. The brain is not merely structure, it is function. Synaptic plasticity, neuroinflammation, vascular health, sleep quality, these shape cognition more dynamically than a static picture ever could. And when we anchor too tightly to imaging, we risk labeling normal aging as disease. Once, I had a patient tell me, after I read the report, I started doubting every thought I had. That doubt became heavier than any lesion. So I ask you gently, if a scan cannot reliably predict who will remain sharp and who will decline, what exactly are we hoping it will give us? When memory wavers, the real story often lives far from the magnet of an MRI machine. Cognition is not a photograph, it is metabolism, sleep architecture, vascular flow, and synaptic plasticity unfolding in real time. The hippocampus does not function in isolation. It depends on oxygen delivery, glucose regulation, circadian rhythm, and micronutrients that quietly sustain neuronal repair. At 5, sleep. Fragmented rest disrupts glymphatic clearance, the nightly system that helps wash metabolic waste from the brain. At 4, medications. Certain sedatives, anticholinergics, and even common prescriptions can cloud attention in older adults. At 3, metabolic health. Insulin resistance and vascular stiffness influence cerebral blood flow. At 2, mood. Depression can mimic cognitive decline with striking precision. And at 1, reversible deficiencies, such as vitamin B12, that can impair nerve function if overlooked. Large reviews in geriatric medicine consistently show that many mild cognitive complaints are linked to these modifiable contributors rather than structural neurodegeneration alone. Livingston et al., 2020. Yet none of them are visible as a dramatic spot on imaging. I remember a retired teacher, 74, convinced she was losing her mind. Her MRI showed age-related changes. The real culprit? Severe sleep apnea disrupting oxygenation each night. When her sleep improved, so did her clarity. So let me ask you something quietly powerful. What if the brain is asking for restoration, not a photograph? The third checkup I hesitate to embrace as routine is the cardiac stress test performed in people who feel entirely well. It is often ordered before minor surgeries or as part of a standardized protocol, a treadmill, wires across the chest, a search for hidden danger. The logic sounds protective, but physiology in older adults is complex, and testing can mislead. At 4, an asymptomatic person agrees just to be safe. At 3, the treadmill produces a borderline abnormality, a subtle ECG change or imaging artifact. At 2, cardiology referrals follow, along with more advanced imaging. And at 1, a cardiac catheterization, invasive, carrying risks of bleeding, stroke, or vascular injury, all to investigate a signal that may have been false. False positives rise with age because baseline ECG changes and reduced exercise capacity are common. Studies evaluating preoperative stress testing in low-risk, asymptomatic patients show limited evidence of improved outcomes. Yet, once an abnormality appears, the cascade rarely reverses. I have seen seniors who climbed stairs daily without chest pain suddenly labeled cardiac patients after an equivocal test. Their confidence faltered, their activity decreased. Ironically, deconditioning followed, the very risk factor we hoped to prevent. The heart is not simply an electrical tracing under stress. It is mitochondrial output, endothelial function, and cardiorespiratory fitness expressed through VO2 and recovery time. Sometimes daily life, brisk walking, stair climbing, carrying groceries, reveals more than a laboratory treadmill. So I ask you carefully, if you feel strong and symptom-free, is the test protecting you or protecting our fear of uncertainty? There is a quieter way to understand the heart, not through provocation, but through observation of lived capacity. Your body already performs a stress test every day. When you rise from a chair, climb stairs, or walk uphill and recover your breath within moments, you are witnessing integrated physiology, cardiac output, vascular elasticity, mitochondrial respiration, autonomic balance. At 3, notice endurance. Can you sustain moderate activity without chest discomfort? At 2, observe recovery. Does your breathing settle predictably? At 1, reflect on resilience. Do you feel capable in your daily environment? Functional measures often correlate strongly with outcomes in older adults. Cardiorespiratory fitness, frequently expressed as VO2 max, has been associated with longevity across cohort studies. This does not mean numbers are destiny, but it highlights something profound. Performance can be more predictive than pictures. There are also diagnostic tools that guide prevention rather than escalate intervention, such as coronary artery calcium scoring, which assesses calcified plaque burden and informs risk discussions. Yet, even then, context matters. A number without a narrative can mislead as easily as an image. I once spoke with a 70-year-old who said, "I stopped gardening after my stress test scare." Months later, his stamina declined. The heart thrives on use, not on labels. So consider this gently. What does your daily life say about your cardiovascular strength? And are we listening closely enough to it? The 4th checkup that demands thoughtful restraint is colonoscopy after age 75. For decades, it has been a pillar of preventative medicine, and for many adults earlier in life, it remains valuable. But aging changes the mathematics of benefit and risk. Colon cancer typically develops slowly, often over 5 to 10 years through the adenoma-carcinoma sequence. When life expectancy is limited by other conditions, the probability that a newly discovered, slow-growing lesion would meaningfully alter lifespan diminishes. Meanwhile, the risks of the procedure increase with age. Studies show that complication rates, including bleeding and perforation, are higher in older adults compared to younger populations. At 4, there is the bowel preparation, which can cause dehydration and electrolyte imbalance.
At 3, sedation risks, particularly in those with frailty or cardiopulmonary disease. At 2, the small but serious risk of perforation. And at 1, the emotional toll of recovery from an invasive test that may never have been necessary. Guidelines increasingly emphasize individualized decision-making beyond 75, weighing comorbidities and functional status rather than applying blanket rules. This is not neglect, it is precision. I once asked an 82-year-old patient what mattered most to her. She said, "Staying steady on my feet and enjoying Sunday dinners." That clarity reframed everything. So I ask you, are we measuring longevity in years alone, or in independence and joy? When you step back, a pattern emerges. A precautionary test, an incidental finding, a referral, a procedure, a complication. The cascade effect is not born of malice. It is born of fear. Fear of missing something, fear of uncertainty, fear of aging itself. But aging is not an error in need of constant correction. It is a biological process shaped by cellular senescence, mitochondrial adaptation, circadian rhythm, and resilience. Health, especially after 60, is less about pristine scans and more about preserved function. Can you move with confidence? Can you think with clarity? Can you connect with others? Maintain purpose. Research on social connection and longevity consistently shows associations between strong relationships and improved survival. No MRI captures that. No treadmill quantifies dignity. I am not arguing against medicine. I am arguing for discernment. Before agreeing to any test, ask 3 questions. Why is this necessary? What happens if we find something incidental? What are the real risks? Evidence-based care thrives on dialogue, not reflex. Sometimes the bravest medical decision is not escalation, but pause. Sometimes the healthiest choice is to protect your physiology from unnecessary intervention. And sometimes, after thoughtful discussion with a qualified clinician, the answer may indeed be to proceed, but with eyes open. So let me leave you with this. If health is the ability to live fully in the time you have, what choices today will truly protect that freedom?